talk about some strategies that they've employed in TM patients.
See if I can't move this over just a little bit here. Well, I'm Kelly Nanzetta, and as Doug said, I'm a physical therapist at Johns Hopkins in the outpatient department, and Brooke Harris, who will be joining me soon, is an occupational therapist. Before I even get started, I just want to thank Dr. Kerr again for including us in the Transverse Myelitis team at Johns Hopkins, and of course for inviting us to speak today. We have a short time, so we're just going to speak very briefly, a broad view of our therapy evaluations and interventions. And we're hoping that by knowing what OT and PT should include, or at least consider in evaluations and treatments, that you can be your own best advocate. Maybe I can get a show of hands for those of you with TM. How many people had inpatient PT or OT? How many people, keep your hands up if you went to inpatient rehab? All right. How many people went to an outpatient clinic after that? Pretty good. Okay. We're going to address that a little bit more in the future, too. Thank you. PT and OT at Johns Hopkins. Let me advance here. Okay. We've seen about 15 patients or clients over the last year each. And so we're learning as we go. But we really feel fortunate to be a part of Dr. Kerr's team and to have exposure that maybe other therapists might not have in this way. Most of the TM patients that are sent to us are sent on a consult basis. And what I mean by that is that most of you that have seen us are from out of state. So we, most of the time, not always, but most of the time have a one-shot deal, so to speak. So our types of interventions may vary from other centers like Darlene, who I've met, who's in a neuro rehab type of setting. So what is it that we're able to do? Well, one thing we may do is recommend a consultation to the physician to consider and the patients to maybe a recreational therapist, an aqua therapist, a PT or OT in an outpatient setting if that's not being pursued and we feel that there might be needs, and other things such as an orthotist or equipment dealer. We may also make recommendations to an outpatient PT/OT that someone with TM is seeing, and this is really done not as we recommend this, but as considerations that might want to be made, and really an information exchange. Lastly, if we can, we might make some instructions in home exercises, but of course these have to be taught and learned in this one session, so they'd be pretty basic. Okay. Our recommendations are, of course, based upon the evaluation. And we tailor this as needed. We may do anywhere between 45 minutes and 90 minutes of evaluation time, and that is one-on-one. We first, of course, gather all past medical history, including history of TM, but other things as well, and medications. This kind of thing might assist us because, for example, if we find out there's a history of osteoporosis, that might change the way we do passive range of motion or stretching. In addition, if we find that a patient is taking baclofen, that might change at least our interpretation of strength and spasticity measurements. Moving then through the evaluation, which I'll do for PT and then Brooke will do for occupational therapy. We take a look at the subjective eval. So this is really just a conversation. We ask about pain levels and sometimes rank this on a scale from 0 to 10. Spasticity levels, and this is really how it might be affecting function, functional mobility and endurance issues, perception of daily activity level, are you able to go to work, are you able to do self-care, that kind of thing. And you all have probably been through this type of questioning on more than one occasion. But we also want to take a look at the rehab that you have been exposed to and what you might be doing now. Of course, your support, and that would be family and friends, and also involvement in a support group, TMA, and if you're not, then we usually recommend that you do so. We want to get an idea of your home environment, and of course, any other problems or challenges that you might see or goals that you'd like to get out of this session, because the truth is, we're here for you. Moving on then to the objective evaluation, we take a look at range of motion, really of the entire body. And this is where I'd like to just throw in, especially for the PTs in the group, which I've had the fortune to meet through the weekend, heterotopic ossification. This is something that's been studied and discussed in trauma, but not really until recently neurogenically. And what this is bone formation between muscle layers. And it tends to occur near joints, but not in joints. What does HO do? Has anyone been exposed to this? Thought I saw a hand go up. What it can do is significantly decrease range of motion. And as Dr. DeLatour was talking about in her gait discussion yesterday, decrease in range of motion, whether it's from spasticity or from bone formation, can have a significant effect on your functional mobility. In a study done by Daley et al., and this was published just recently in March of this year, they looked at 377 neurologic patients, including TM, and found that HO occurred in 4% of their population. So it's rare, but it is something that if it's caught early, physicians can then do something about. And as a therapist, you may be the first person who really notices it. So at least be aware is the take-home message with that. We do manual muscle testing throughout, which is strength testing, of course, and we get a concept of tone or spasticity using the Ashworth scale if we need to. If there's a lot of tone, this sort of renders our manual muscle testing meaningless, and then we make strength measurements in different ways. Functional mobility, we consider transfers, such as bed mobility and movement from the bed to the chair. And we take a look at other mobility that's important, either ambulation or in a wheelchair. And you all sort of know all this. Let's see if I can get the mouse going. There it is. All right. Oh, that didn't work. Yeah. How do you make it go backwards?
One more.
There it is. Okay. If I want to double click on this box. There it is. Nope.
It's not.
This one.
Yeah.
Okay, there it is. Thank you. Sorry about that. I just wanted to sort of get across the framework that you and your therapist might be thinking through, and this would be more acutely, but with a lesion, if we take a look at a spinal cord lesion at certain levels, we need to think about what would be an appropriate functional mobility goal to set. And when I say framework, I mean this is a very general concept, because these were based on abilities at a complete spinal cord injury, and even in that consideration there's differences between patients, such as body habitus, upper extremity strength, motivation, that sort of thing. But just in general, if you were to take a look at a complete C5 lesion, functional mobility that can be expected for goal setting is with assistance, if you can read across, it's a little bit scrunched in, for bed mobility, and assistance for wheelchairs. I don't want to waste too much time, so skipping down to a T7 level, if it was a complete lesion, which most of TM is not, bed mobility would be independent, wheelchair transfer is independent, and gait could be expected with training to achieve a swing 2 style of gait. So if you can sort of refer back to Dr. DeLatour, she had a slide of that one. See if I can do this. Yay. Okay. Another thing we consider in functional mobility, just very quickly, is ergonomics, and I can sort of refer back to the gentleman in the center there who yesterday brought up, well, my knee sort of goes backwards. Is that something I should worry about or I should change? Well, sometimes it really is, and that's another thing we may pick up on our consult that can be changed. It's hyperextension with weight bearing in the knee, and it can, over time, can sometimes break down the knee joint, which you want to avoid. We also take a look at reflexes, sometimes high-level balance. Endurance is often an issue, and sensation, where we look at dermatome levels, and that can be used for reassessments later. What sorts of interventions can we recommend? Well, often the TM team recommends Aqua Therapy, and this is for a lot of different reasons. How many people here are involved in Aqua Therapy right now? Good. So you all have some experience in this. For a lot of people, it decreases tone, not just while in the water, but up to 2 hours later, which is a good thing. It helps to also just allow freer movement in the water with less load on the joints, and it allows for some cardiovascular conditioning, which would sometimes quite a challenge. We also sometimes make recommendations to utilize a standing frame, and this is usually in a subacute situation, and this also has a lot of advantages. And as I had mentioned before, we recommend home exercises if we can. Just let me finish up a few things here, and then we'll let Brooke go. Brooke and I are finding that quite a few people that have given us their experiences note that they've had PT or OT acutely or even in rehab, but if they've had outpatient at all, it's something that they do for one phase and then don't come back. And I actually saw quite a few hands still up, so that's good, and I'd like to talk about that a little bit more. Along those lines, a study by Chan and Bowie in '96, they were actually studying lupus with TM characteristics and whether steroids would be helpful. But one thing that was mentioned in their study was that only 15% of their patients were sent to an inpatient rehab unit. And 86% of them were either paraparetic or tetraparetic. So I can't go back and say, well, those patients should have been sent to inpatient rehab. But what I can say is that at least raises the question as to whether inpatient rehab is being recommended as much as it should be. And probably the same question goes for outpatient therapy. What's the appropriate utilization there? And Brooke is going to discuss this in a little bit more detail. Just want to leave you with just bringing up the point of Dr. Kosis from Yale, who spoke yesterday, that the role of rehab in the future, if anything, is just going to grow, because if we're looking at transplantation, then what we would like to do is take advantage of, if there's any motor working there at all that we can work with, then that's when rehab can really play a role, because we can take advantage of the plasticity of the brain at that point. And that's sort of how the standing frame and the weight-reduced treadmill works as well. So without going over too much, I'd like to bring Brooke Harris up here and talk a little bit about occupational therapy.
Thanks, Kelly. Good afternoon. What I'm going to do is just take a few minutes and talk about the role of occupational therapy in the transverse myelitis population. As with the PT evaluation, our occupational therapy evaluation also begins with the review of all of the past medical history, including their history of TM, their medications, and their level of functioning prior to their onset of transverse myelitis. Now, depending upon who has evaluated the patient first, either physical or occupational therapy, some of this information may be shared between the disciplines so it's not so redundant for the patient. And then what we'll do is just verify that information with the patient. I think it's really important to have a good understanding of the patient's level of functioning prior to their onset of TM. This gives us a little bit of insight into what some of the patient's own goals might be as we go along in the evaluation process. Moving along in the evaluation process, I like to get a detailed social history, including their marital status, their family and support system, information about their home environment, their work history, and their leisure interests. it's extremely important for us to know who's involved in this person's life on a daily basis, either physically, socially, or emotionally. And if the patient is accompanied by their family member or a relative or a friend to our clinic, then I will try and involve those other people in our evaluation process as much as we can and as the circumstances allow. Information about the patient's home environment should include, do they live in an apartment, a home? Is this home a one-story or a two-story home? Are there any physical barriers that need to be considered, such as stairs, narrow hallways, doorways, or bathrooms that will need to be considered for wheelchair mobility issues later on in the evaluation? The work history should include, is the patient working? Did they work prior to their onset of TM? Were they working full-time or part-time? Are they interested in returning to work or their previous job? And with school-age clients, I also like to know, have they returned to school? Are they being tutored at home or homeschooled? And how are they adjusting to these issues with school? And then finally, I like to get a little bit of information about the client's leisure interests. Do these people have any hobbies or things that they like to do in their free time? As Dr. Wegner had so eloquently put earlier, that for a lot of patients, TM has become a full-time job and just dealing with it on a 24-hour, 7-day-a-week basis. And it's hard for people to even consider going back to things I used to like to do in my free time. So at this point, if patients aren't able to indicate that they still have a lot of their leisure interests or hobbies, I'll consider that they need to maybe see the recreational therapist. Okay. Moving on, the evaluation is the subjective portion, which is similar to what Kelly stated in the physical therapy eval. I like to know what their current and previous rehab programs have been, what their own goals are, and then any other subjective reports from the patient regarding their condition. And this is the best time for us to really be active listeners and get a good insight into what are the client's goals, because that's going to dictate what we do in the treatment recommendation portion of the evaluation. In the objective portion of the evaluation, I'll look at upper extremity range of motion, upper extremity strength, sensation testing, balance, functional transfers, and then activities of daily living. Once again, depending on who has seen the patient first, either physical or occupational therapy, we may share the upper extremity range of motion and strength information, because for most of these patients, most of their involvement is in thoracic level down, so most of their deficits will be related to their lower extremities. But I will still test these items independently in physical therapy at times, especially if they have higher thoracic level involvement, because this may be important for wheelchair issues. Sensation testing will be looked at in more detail, again, if there's involvement higher than the mid-thoracic level. Balance and functional transfers also give me good insight into issues that may come up for wheelchair mobility. And then finally, and most importantly, I'm extremely concerned about the patient's activities of daily living. And this is probably one of the most detailed portions of my eval. I like to know as much information as I can about their current functional abilities and their current deficits. This includes their level of independence with items such as dressing, bathing, grooming, toileting, and their household responsibilities, and of course their outside of their home responsibilities, work or school issues. And most of this information I take by subjective report from the clients just for time's sake, but there are times when I actually have clients or patients do specific ADL tasks in the clinic, because this just gives me a better idea of problems that they may be having with their ADLs, and we can do some creative problem solving while they're in the clinic with me. At Hopkins, I do most of the seating and positioning, so I include this in my consultation with the transverse myelitis patients. And what I will look at is the appropriateness of the current wheelchair that they have if they are using a wheelchair. That includes the style, size, and accessories of the wheelchair. With their style, I take note whether it's a manual or a power wheelchair. And for manual wheelchairs, are they in a standard weight, a lightweight, or ultra lightweight wheelchair? And for the ultra lightweight wheelchairs, I'll also take a look at the camber and squeeze on their wheelchairs. And squeeze is just the difference between the seat to floor height in the rear and the front of the chair. Squeeze with ultra lightweight chairs, they will have a lower seat to floor height in the rear and a higher seat to floor height in the front. I will look at the size of their wheelchair. Are they in the appropriate size, seat depth and width for their wheelchair, and then accessories. When clients are initially fit for their wheelchairs after their acute onset of TM, oftentimes they're not quite sure, this is all so new and very overwhelming, they're not sure how the wheelchair should fit, how it should feel, and how it should really function for them. So when they come to us in our clinic, they're often in a more chronic phase of their symptoms and have a better idea of how they like their wheelchair to function and work for them. So this is a great opportunity for me to check those things out, make sure they are in the appropriate equipment. And also they've had physical changes that have occurred over the time since their acute onset, so this is a great time to check those things. I can't emphasize enough for patients how important proper seat depth and width in their wheelchairs and seat to floor height is to ensure proper weight bearing, proper trunk stability, and for minimizing upper extremity overuse syndromes. And then finally I'll check out the accessories on their wheelchair. Sometimes changing one or several of the accessories on the wheelchairs can make the difference in increasing their independent mobility with their wheelchair. For example, I had one client who we suggested changing her foot plates from standard foot plates to the tubular style foot plate, and this just made it much easier to do a sit pivot type of transfer right from her wheelchair to a bed or another chair or another surface. And then as far as treatment strategies, once the evaluation is completed, we'll do things for home exercise programs, recommendations for adaptive equipment, recommendations for adapted ADL techniques, and then any wheelchair recommendations. All treatment recommendations are of course based upon the results of the evaluation, and they're customized for each client. Our role at Hopkins has been more one of a consultant, so we try and round out each client's therapy experiences and take in all the experiences that they already come with to our clinic. Oftentimes there's been many issues and circumstances that have limited clients' access and utilization of OT and PT services. At this point, with the home exercise programs, I may recommend strengthening or stretching programs, adaptive equipment such as reachers, dressing aids, tub benches, etc. Anything that they're not already using that may be helpful for them if they're interested. I may recommend adapted ADL techniques. For example, I had a client who had been shipped out of her inpatient rehab unit a little early just because of insurance issues. And she was fairly comfortable with her mobility at that point and wanted to get more independent with just some of her basic things, such as getting dressed. And she had received a handout on how to do this, but never had the opportunity to practice. So we kind of went through and problem-solved some strategies for her to be independent with those tasks. And then other times I'll just problem-solve with strategies that patients may already be using for their ADLs. And then I will help patients follow up on any wheelchair recommendations that I may make, and help them follow through with their home therapist or a DME supplier closer to home. Finally, one thing that we've done here at Hopkins is we've tried to develop a form so that we can write a brief summary of the physical and occupational therapy evaluations and then write our recommendations down so the patients can take a copy of that with them to their home therapists, and so we can kind of communicate if they need to call us or if we need to touch base with each other on those recommendations. And then lastly, again, our role as PT and OT here at Hopkins is just a very small piece of the continuum of rehabilitative care for patients with transverse myelitis. So to conclude, we'd like you to consider the possibilities of long-term follow-up with OT and PT. We're all aware that there are many factors that limit adequate rehabilitative follow-up. There is a demonstrated need for long-term rehabilitative care and support long after the acute phase of rehab and onset of TM. An inpatient rehab stay should always be considered, and we suggest that outpatient therapists consider reassessment every 3 to 6 months, as this gives the opportunity to make adjustments to home exercise programs, to reassess strength, range of motion, balance, and stability, and to adjust for any physical changes that have occurred over time. And this, hopefully, in the long run, will improve the client's functional mobility and their quality of life. And we'd just like to thank you for your time today, and we'll be happy to answer any questions at the refreshment break, which I think is next. So, thank you.